Okay, well, thank you very much for the invitation. So I'll be talking, I'm a leukemia doctor at MD Anderson Cancer Center in Houston, Texas, and I will be talking about how I treat newly diagnosed ALL, and I'll be focusing a lot about, I think, the more exciting things that are coming, some of which are initially in some research studies, but some that I think are becoming standard of care now that we have more data. So next slide. These are my disclosures. So these are the historical outcomes for adults with newly diagnosed ALL. And I emphasize historical because we've made a lot of improvements, but this is just to show where we're coming from. So for what we would call a younger adult with ALL, this is generally defined as someone between 18 to 60 years of age approximately. We can generally achieve very high rates of remission with our standard chemotherapy, but unfortunately, we've historically only been able to cure around 40% of patients. Now, the outcomes have been even worse for patients who are older, patients who are 60 years of age and older, because they tolerate chemotherapy less well. They have more comorbidities, and so they have higher rates of mortality with standard intensive chemotherapy. The cure rate for these patients has historically been only around 20%, and actually many of these patients have not even received treatment because many physicians have thought that it was relatively futile to treat a patient of this age range because they felt that the outcomes were so poor. But of course, we've made significant improvements since then. Next slide. So we have seen success, as I'll highlight in this talk. What are some reasons why we've had success in patients with adults with ALL? So I think two broad categories. One is we're now better at identifying patients who have what we would call high-risk ALL. These are patients that have, for example, poor risk cytogenetic or molecular features, patients who have suboptimal response to chemotherapy, such as residual MRD, measurable residual disease. And so these patients might be considered for more aggressive therapy, such as stem cell transplant or potentially blinatumomab, which can be used to target MRD. And then the other is the development of new agents. So that would be, for example, in Philadelphia-chromosome-positive ALL, we now have better tyrosine kinase inhibitors to target the abnormality that causes this type of ALL. We have the development of various antibody therapies, such as blinatumomab, inotuzumab, ozogamicin, and CAR T cells that are approved for relapse refractory ALL. But these are now being used in the frontline setting in many clinical trials, and some are becoming more standard to be used in the frontline setting now based on clinical trial data that's emerging. And the outcome for these patients seems to be better than when treated with chemotherapy alone. Next slide. So if we want to just think very simply about how, when I have a patient with newly diagnosed ALL, how do I think about that patient to start thinking about what is the frontline treatment regimen I'd recommend? So the first thing I want to look at is it B cell or T cell? About 75% of patients will be B cell, about a quarter will be T cell. And then among those with B cell ALL, do they have the Philadelphia chromosome? So do they have the BCR-ABL translocation, which means they have Philadelphia chromosome-positive ALL, or are they Philadelphia chromosome negative? And once we put patients into these three broad categories, we can start to develop the frontline treatment plan. But there are a number of other considerations that we need to consider when deciding the treatment plan, such as the age. So if a patient's older, maybe use lower intensive chemotherapy, or if the patient has many comorbidities. If we're thinking about using one of these novel antibodies that target specific proteins on the leukemia cells, do they express those targets? So do they have CD19, which is the target of blinatumomab? Do they have CD22, which is the target of inotuzumab, ozogamicin? And also, there are some patients that have something called Philadelphia chromosome-like ALL, and there are some abnormalities within those patients that might be targetable in the frontline setting. Next slide. So broadly speaking, what are the chemotherapy backbone regimens that we use in ALL? So we can think of this in probably three categories. So there are patients we call adolescent and young adults. These are, generally speaking, patients defined as those between 18 to around 39 years of age. Many would advocate to use what's called a quote-unquote pediatric-inspired regimen. These are regimens that were initially designed for children and now are being used in older age groups. And asparaginase is a key drug in these regimens. But some of us, and I do this, treat these patients still with adult regimens. This would be a regimen such as hyper-CVAD. That's a common regimen that's used, but there are many other ones as well. For patients who are outside of this adolescent and young adult age range, but are not in the older population, those between maybe 40 to 60, we often use an adult regimen such as hyper-CVAD. And for older patients, those who are 60 years of age and older, we're typically using lower intensity regimens because these patients don't tolerate intensive chemotherapy well. And then, of course, there's the consideration of should we be adding immunotherapies to these frontline regimens? It's standard of care to add rituximab, which targets CD20 if patients are CD20 positive. It's now, I would argue, standard of care to use blinatumomab, which targets CD19 for these patients. And then there are some regimens that do use inotuzumab ozogamicin, but this is, I would say, less standard. There's also a number of clinical trials ongoing that are looking at chemotherapy-free regimens for patients who are either much older, those patients who are 70 years of age and older, and also those patients who have Philadelphia-chromosome-positive ALL. We're now sometimes treating these patients without chemotherapy. Next slide. So when I talk about, we can talk about a number of different regimens, but taking one of the simpler ones that's commonly used, certainly in the US, would be hyper-CVAD. And just to give you a general sense of what, when we're talking about a frontline treatment regimen, what does it entail? So hyper-CVAD is 8 cycles of high-dose chemotherapy. It alternates 2 types of chemotherapy. One's actual hyper-CVAD. One is high-dose methotrexate and cytarabine. After those 8 cycles of chemotherapy, patients then receive a maintenance phase. This is with a regimen called POMP. And so essentially, it's at least 3 years of treatment to complete all of the therapy for ALL. Now, along with this, we always would add rituximab, again, if patients are CD20 positive. And then all patients with ALL should have prevention against recurrence in the central nervous system. And so we give them intrathecal chemotherapy to help prevent this. And this is part of really all ALL regimens. Next slide. So as I've already alluded to, these are 2 drugs that have been approved. These are actually approved in the relapsed refractory setting. So these are approved for patients who the disease has come back, but many of us are now using these, and there are many clinical trials using these agents in the frontline setting. And we do believe that these may lead to better outcomes than chemotherapy alone. So inotuzumab ozogamicin is an antibody drug conjugate that targets CD22. This is expressed on most most leukemia that's B cell in origin. It delivers the drug, a toxin directly to the CD22 positive leukemia cells. Blinatumomab is an immune therapy that it engages the CD3 positive T cells, the normal immune system of the patient, to engage with the CD19 positive leukemia cells and causes cell death through that immune mechanism. Next slide. So blinatumomab is approved in the US and outside the US for patients who have MRD positive disease. And so this is a study that was led by Dr. Gokuje, who's going to talk shortly. But essentially, this was a study of patients who have positive MRD. So they have they're in some form of remission after initial chemotherapy. But when we use more sensitive tests, we can see that they have some amount of residual leukemia. In this study, it was defined as 0.1% or higher. Then patients receive blinatumomab, and we see very high rates of clearance of this leukemia with blinatumomab. So approximately 80% of patients will no longer have any detectable leukemia after we give them blinatumomab for this indication. Patients who have a response to this, which is, again, the vast majority, have better survival. And that was part of the reason why this was ultimately approved. I think one big question is always, after a patient, if they have positive MRD and then they receive blinatumomab and then it clears, do they need to go to transplant or not? And this is a really controversial question. There's not a lot of clear data in terms of what we should do afterwards, and that's kind of an individualized decision. But this is a very important tool that we have for clearance of MRD in patients with B-cell ALL. Next slide. And so that was the study that led to the approval of blinatumomab for MRD positive disease. Now we have a more recent randomized phase 3 study that looks at blinatumomab even for patients who have MRD negative disease. So patients who receive some amount of chemotherapy, we don't detect any leukemia. In this study, patients were then randomized to either continue to receive standard chemotherapy or still to receive blinatumomab despite the fact that we don't see any leukemia. And impressively, this study showed a very significant improvement in overall survival for patients who received blinatumomab, suggesting that we should be giving blinatumomab across the board for patients in the frontline setting, regardless of whether they have MRD or not. Now, it's important to note that this was not what we call a registrational study. So there's not an FDA approval, at least in the US, for example, for blinatumomab in this setting, but still we consider this to be, based on the survival data, something that if patients can get, I always recommend this for them. Next slide. So how can we further optimize frontline therapy? And so one thing that we've done at MD Anderson, and this is just to show kind of the way that we're trying to think about how will the field evolve in the future, is that we've altered the hyper-CVAD regimen to actually incorporate these two very active drugs that we have, blinatumomab and inotuzumab, universally into the frontline setting for all patients. And so what we've done is we've shortened the total amount of chemotherapy in hyper-CVAD from 8 cycles to 4 cycles. Patients receive 4 cycles of chemotherapy, then 4 cycles of blinatumomab, and then they receive a shortened maintenance phase that's about 1.5 years rather than the 3 years of pump, but alternating with blinatumomab. And we also integrate inotuzumab ozogamicin into the frontline setting. So the goal is to give all of the most effective drugs we have to patients in the very beginning when they're first diagnosed to increase the likelihood that that patient is cured. Next slide. And we've seen very encouraging data so far. So if we look at patients who received hyper-CVAD with blinatumomab, this is without the addition of inotuzumab, we had a 3-year survival around 80%, which is very good in the setting of B-cell ALL. And obviously the data are still early, but we have seen very encouraging data so far after we've added inotuzumab to this regimen. And we haven't seen any patients who have died from leukemia so far, but the follow-up is still short. We need to wait for longer term follow-up, but it just shows how we might be improving outcomes even further by using both of these drugs in the frontline setting. Next slide. So what about for patients who are older? As I mentioned, patients who are 60 and older don't tolerate standard intensive chemotherapy well. If we give them standard intensive chemotherapy, the long-term survival rates are only around 20% because these patients don't tolerate therapy well because of their age and other comorbidities. So what we and others have done is ask the question, can we use lower intensity chemotherapy or even chemotherapy-free regimens and rely more on these immune therapies, the inotuzumab ozogamicin and the blinatumomab, to see if we can improve outcomes with less toxicity for these patients? So this is a study that we're also doing at our institution at MD Anderson, where we use low-dose chemotherapy. So this is not hyper-CVAD, although it's based on hyper-CVAD. We call it mini hyper-CVD. It's lower dose chemotherapy, and we also remove one of the drugs, the anthracycline, which causes a lot of the low blood counts. But essentially 4 cycles of low-intensity chemotherapy along with inotuzumab ozogamicin, then 4 cycles of blinatumomab, and then the same pump and blinatumomab maintenance phase. So much less intensive therapy, but using a lot of immunotherapy instead to hopefully improve outcomes. Next slide. And so I won't go into all the data, but this is just to show you that if we actually look at patients in the over 60 years of age, you can see this is patients at MD Anderson treated by decade. And you can see we didn't really make much improvement up to about 2010. And this is because all we had for these patients was different combinations of chemotherapy. Around 2010, we started using this regimen of lower dose chemotherapy, initially adding inotuzumab and then later adding blinatumomab. And you can see a very dramatic improvement in the survival of patients 60 years of age and older that we've treated at our institution. And I think this is because of the introduction of these better drugs, inotuzumab and blinatumomab. And actually, we could see a 5-year survival around 50% in this older population, which is more than double what we expect based on historical outcomes. So we're very encouraged by this, and we continue to do these studies to evaluate the combination of all these drugs in the frontline setting in this older population. Next slide. So moving on briefly to Philadelphia-chromosome-positive ALL. So this is a specific subtype of B-cell ALL. There are some general principles in treating patients with Ph++ ALL. First of all patients should receive a BCR-ABL tyrosine kinase inhibitor. There are various options for this. You can go from first-generation TKI imatinib, second-generation TKI dasatinib and nilotinib, or third-generation TKI ponatinib. What we've seen across a number of studies is that with each successive generation of TKI, we see deeper response rates and we see what looks like better long-term survival. So our general approach is to try to use the best and most potent of these drugs that we can. And this has led to a lot of important questions for this disease, including what's the role of intensive chemotherapy for these patients? Historically, all of these patients were treated with intensive chemotherapy followed by a stem cell transplant. But now we're asking the question, can we use lower intensive chemotherapy or even chemotherapy-free regimens for these patients? And also, do we still need to transplant all patients with Philadelphia chromosome-positive ALL? And I would say the field is really moving away from that to where we're actually transplanting less and less, and actually probably only the minority of patients with Philadelphia chromosome-positive ALL now. Next slide. So what we have, so this is a study looking at chemotherapy-free regimens. So I won't go over all the history of, treating Ph+-positive ALL, but this is really a big paradigm shift, asking the question, can we treat patients who, again, historically were treated with intensive chemotherapy followed by transplant? Can we treat them with chemotherapy-free regimens, with no chemotherapy, with a good TKI, which our preference is to use ponatinib, as well as blinatumomab, which is an immune therapy, and still hopefully achieve the same or maybe even better outcomes than with intensive chemotherapy. And obviously, we need longer-term follow-up from these studies, but this is a study that we've done at MD Anderson. We treated, at this time of this analysis, we had treated 40 patients, and you can see very excellent overall survival despite the fact that we're using a chemotherapy-free regimen. And importantly, only one of these 40 patients underwent stem cell transplant. So it seems to be not only an effective chemotherapy-free regimen, but also one that may overcome the historical need for stem cell transplant in these patients. Next slide. And this is just to highlight that we are seeing an improvement not only in, as I mentioned, the older population with B-cell ALL, but also in patients with Philadelphia chromosome-positive ALL. You can see if we look at, these are data from MD Anderson by decade. In the pre-TKI era, before we had even imatinib, you can see the outcomes were very poor. Those are those two curves on the bottom. Then when we had the introduction of these tyrosine kinase inhibitors that target the Philadelphia chromosome, we had a definitely significant improvement in survival with imatinib and dasatinib. Then we started doing a study of hyper-CVAD with ponatinib. So this is still chemotherapy, but with ponatinib, and we saw further improvement. That's like the light blue curve. And then more recently, we've been doing chemotherapy-free regimens with ponatinib and immune therapy with blinatumomab. And again, we do need longer-term follow-up, but the data so far seem very encouraging. Next slide. And then just briefly, so what is the role now of stem cell transplant with newly diagnosed ALL now that we have all of these good tools? So first of all, it's important to note that allogeneic stem cell transplant is associated or can be associated with significant morbidity and mortality. And therefore, we really need to properly select patients. So for example, we don't want to send everyone to transplant because if we feel that a patient has a good chance of being cured without transplant, we don't want to subject them to that potential morbidity and mortality. But if a patient has a very high risk of relapse, if we don't, then that's the patient that we would recommend transplant for. So right now, I would say transplant is generally reserved for younger fit patients. We're usually not transplanting patients, in my institution at least, over 60 years of age, unless there's a very good reason for that. And the ones that we select for transplant would be those who have very poor risk cytogenetic or molecular features, or those who have an inadequate response to frontline therapy. So those patients who are persistently MRD positive despite giving them chemotherapy, and ideally also assuming that they're still MRD positive after blinatumomab and or inotuzumab ozogamicin. But in general, the role of transplant is decreasing with better upfront therapies that we have. We've seen that again in the area of Philadelphia chromosome-positive ALL, and I would say we're seeing that broadly speaking in ALL as general, as we're integrating these regimens into the frontline setting. And also we have better drugs to salvage patients in the relapsed refractory setting if they were to relapse. Next slide. So in conclusion, I would argue that there's been a lot of progress in the treatment of adults with ALL, particularly in older patients, patients with B-cell ALL, and patients with Philadelphia chromosome-positive ALL. We didn't talk much about T-cell ALL. That's certainly an area of unmet need. There have been some slight refinements in how we treat T-cell ALL, but we certainly don't have as many good agents as we do for B-cell disease. The optimal frontline therapy is really rapidly evolving, and it's moving in general towards a number of basic principles. So one is, let's use the most active agents we have in the frontline setting. So let's take those drugs that we know are very good in the relapsed refractory setting, such as inotuzumab, ozogamicin, blinatumomab, and let's give them in the very beginning to try to increase the rate of cure, which we have the best chance of achieving when a patient is first diagnosed and starting their first therapy. We're trying to move away to some extent from maybe using less chemotherapy. And in actually some diseases, such as Philadelphia-chromosome-positive ALL, or maybe in much older patients with ALL, such as 70 and older, maybe moving away from chemotherapy entirely. Along with these better options, we have less need for stem cell transplant. We're trying to shorten the duration of therapy by relying again more on these immunotherapies and then shortening the total amount of chemotherapy we give. And ultimately, I would argue that we're seeing across these number of studies that are evaluating these different regimens using immunotherapies, we're seeing higher rates of response, higher rates of MRD negativity, so deeper responses, and ultimately what looks like higher cure rates. And we've seen that in at least one randomized study with blinatumomab. Now, all of that said, I think that a lot of the most exciting things right now in ALL are happening in the context of clinical trials. And so I always encourage patients to consider enrollment on a clinical trial. And I really think that's the best option for most patients, whether they're newly diagnosed or in the relapsed refractory setting. Thank you very much.